you guys left. So I'm just going to um, hit the high points on these slides very quickly, just so they're on record. So let's start with slide 32. And basically the issue, here, let me get to. So one of the big issues here is that what we've got is that the patients, we do see that they may, that often they do present, we talked about this in detail this morning, that they many times may actually present in depression and been treated as depressed patients rather than treating patients with bipolar. So that delays their appropriate treatment. We also see that the treatment that they're getting is going to be suboptimal, since we're basically only going to be focusing on the depressive phase. And then the third thing is, and probably our biggest concern, is going to be a concern of shifting somebody that's in the depressive stage to mania, or potentially get them into a cycle acceleration. The other thing, which we did have some discussion on too, is the fact that the focus with treating bipolar, especially with treating patients with depression that are bipolar, is really tends to be short-term treatment. Let's just see sort of we can get them out of the depression and move forward. So that is, we need to make sure the patients understand that this is probably a chronic disease, and we're going to be treating them for a good part of their life. Then we talked about the cycling, and I showed you this slide where it showed the comparison of the treated versus the untreated. And again, our goal is really to decrease the intensity of the phase. So for example, the manic phase, we don't want it to be as intense. And what we want to do is decrease the intensity of the depressive phase. The other thing we want is to decrease the duration. So if we're treating patients properly, what we should see is not only a decrease in the, I should say over here, be a decrease in the duration, but the other thing too is that we should see a decrease or an lengthening of the time that they are in sort of remission. So one of the big things is that, again, we want the mania not to be as intense and to last for a shorter period of time. We want the depression not to be as intense, shorter duration, and we want a longer period in which between these manic and depressive phases. And again, when we are looking at maintenance and discontinuation phases, some acute things we may have done, gradually taper those off, keep them on prophylactic therapy, which includes counseling, which also includes making sure they're on the right drugs. And a big thing during this is to monitor, okay? What we're looking for with monitoring is we want to address any adverse effects. This may be due to drug interactions. It may be adjusting dosages. We want to keep them therapeutic, and when therapeutic range, specifically with something like lithium, we want to make sure that they're in the therapeutic range. But the big thing is when we're monitoring them, we're looking for efficacy. So is it working? We're looking for adverse events. And if we can minimize those, or at least counsel the patient with those, and we're looking for, so we're basically monitoring efficacy and safety. We're also looking that many of these patients could potentially have a lot of things going on, since many of them may have ongoing chronic disease. So we have to, one thing I didn't mention is we have to differentiate specifically a lot between making sure that the symptoms that they're getting, or if they're not progressing, is to see if it's a disease, if it's a drug, or one of the big things is there another thing that may be going on. So those are the things we're looking at. So that sort of brings us up to date. And basically, what I want to now pick up is we're going to start talking about some of the therapeutic modalities. I told you I was going to send you 2 articles. We actually posted 3. The article on the history of depression tells you a little bit about how the drugs work, or the history of bipolar treatment tells you a little bit about how the drugs work, but sort of how they evolved. But when you look at treatment of bipolar, this sort of a timeline here, I'm not going to be asking you about, any of these particular dates, but really back in the 40s and even 50s, or before the 50s, is the way they treated bipolar many times was electroconvulsive therapy. Then we saw in the 50s, we started seeing lithium evolve. And so we saw the 50s, lithium was there, and then we started seeing the late 50s and the 60s, we started seeing those, what we call these first generation antipsychotics and antidepressants. I guess when I've got this in red, the main thing I'm trying to emphasize or want you guys to be aware of is literally, sort of not when these evolved, but sort of how they evolved, if you will. So these first generation antipsychotics were the things we talked about last weekend. These were the conventional or the typical antipsychotics. You see chlorpromazine, trifluropyrazine, fluphenazine, thioridazine, haloperidol, mesoridazine. And actually of this group of drugs, basically what we really saw was probably chlorpromazine was actually the only one that was actually approved for acute mania. In the 70s, we started seeing the emergence of the anticonvulsants, in particular, two we will talk about today in detail, is carbamazepine and valproate. And we also saw moving to, and starting around the 80s, early 90s, we were seeing gabapentin, lamotrigine, topiramate, oxcarbazepine. If you'll notice, we'll talk that the carbamazepine and the oxcarbazepine are very similarly related. So then we saw, of course, as we talked about last week, we saw the emergence of the atypical antipsychotics really moved in the 90s. And so we've seen a lot more people start moving towards the 90s there with using these atypical antipsychotics. But we still see a lot of use of anticonvulsants. We still see a lot of use of lithium. We see a reduction in the use of these first generation antipsychotics and antidepressants, although they still are being used. All right. But again, I'm not planning on asking. What I really want you to know about this slide is basically we saw lithium has stayed on there, first generation, then we saw the anticonvulsants, and then we saw the second generation agents there. But one of the other things I'll mention is that, there is a lot of, one of the delay in getting people to treatment sometimes is, because we actually saw that at a couple of people that I'm aware of, that actually this was the case, where electroconvulsive therapy was used. And surprisingly, there is people still have the perception with electroconvulsive therapy that it's, the one flew over the cuckoo's nest type situation where it's almost like it's almost like a lobotomy. So there is still a lot of, we've actually seen ECT used a little bit more. And, but one of the big things when ECT comes up is that people's perception of that. I mean, think about if you had, I see, Rebecca, you said some of them are still we still see it used here in Georgia. Well, I see a lot of states that it's being used in, but one of the things is you see people that hear about someone having ECT and they have in their mind, they just have this, this person must be really, really sick to have this. So, but we do see, like the one person I know that that actually underwent it was refractory to a lot of other things, and her husband said it was talking about that it was much more humane than he thought it was, with his perception. But again, one of the issues with ECT is there's a lot of perceptions to do that. I didn't, I wasn't aware that the insurance was more difficult. Now, in this particular person I know specifically, the husband and wife that did it, is because it was everything else had been tried. So therefore the insurance company did carry it. Okay, now, one of the things that comes into, when you read these clinical trials, if you sat down and read a lot of these clinical trials, one of the things that will that'll come out is, depending on the trial, you will see a lot of different things. So what I've done is just sort of give you a summary of efficacy evidence that has come from the randomized controlled trials. Of course, the RCTs these are considered the gold standard, you know, for treatment, and they seem to hold a lot of weight. But on the other hand, you have to be aware that sometimes, depending on what these randomized controlled trials were, they can be well designed, and they can be sometimes statistically manipulated and so forth. For example, these prescription drugs that I told you that were so expensive. The interesting thing is that their randomized controlled trial for efficacy was they took the combination product of ibuprofen and I think it was famotidine, so a NSAID plus a H2 blocker, and they compared it to patients with getting ibuprofen. Well, the problem with that is that, yeah, when you use these, basically, the problem is that you would expect that you would have less gastric bleeds if you put something in there to protect the stomach. Probably a better type study would have been a comparison of the combination product to a group that had the individual agents. So when you see these randomized controlled trials, you've got to look at them closely. Typically, they're going to be better because of the way they're designed, but again, you have to look at them. So when you looked at these randomized controlled trials, and I think this came from some product literature that was promoting ziprasidone because it was sort of highlighted here. But what you see is that, for example, a lot of these drugs work pretty well for the manic phase, okay? So used as monotherapy, lithium worked, divalproex, which is valproic acid, the anticonvulsants, carbamazepine, lamotrigine. Lamotrigine was an interesting one because there was really not an effectiveness shown with that one. And the MD is not determined. But what you find is that a lot of the drugs work pretty well for for acute mania as monotherapy. In combination therapy, several of them work, but some of them had not been determined. But what we found was with the depressive phase, one of the big things is that a lot of the drugs we have just did not seem to work as well for the depressive phase. So it's usually easier to treat the manic phase. And, you know, with lithium, we'll talk about it in detail this afternoon. But with lithium, I mean, it works well for mania. But one of the things that comes into to an issue is when it comes into use with this. So when it comes in for acute depression, worked in some cases, not as well in others. So Jason, with regard to the definition of combination therapy is combined with another drug. That's just a broad category. So we'll talk about some of these combinations. And Maribel, when it has these type of charts, a lot of people like to use them. When you have the plus minus, that is, there are some studies that show it worked. There's some studies that show it didn't work. So so this is primarily only pharmacotherapy, correct, Jason? And I'm not going to ask you on these. The main thing on this slide here is clearly many of these drugs work primarily for the manic phase, both, you know, in combination therapy, but in monotherapy we see that, and we'll talk about this a little bit more. We have we have a little bit more difficulty with some of these agents on the depressive phase, and so that's one of the big issues. Drug companies, when they're doing a lot of these randomized control trials, many times they may not have the cognitive therapy, and it may only be pharmacotherapy because that throws a variable in. We'd like to see it and we know it'll work, but then you have to sort of then you have to run a group with only pharmacotherapy, and that creates some issues. So when they're doing a lot of these drug trials, a lot of times they will have not, you know, they will primarily have a drug trial, which is primarily drug trial with minimal therapy. Okay, so let's go to lithium. Okay, this is one of the big drugs that's been around for forever. I mean, it's actually, if you look at the history of lithium, one of the things you see is that I find this slide just sort of interesting, is why I threw it in there, is sometimes people, especially when the new drugs were coming out and so forth, is they forget sometimes how we discover the others. So right, Rebecca, pretty much on the previous slide is I'm going to say we'll talk about these as we go through the individual drugs, so we'll reemphasize that. But basically, most of the drugs work pretty well for mania, but the depressive and maintenance phase is a little bit more difficult. So one of the things is, back in the 500 to 600, we saw that they were using alkaline waters. And what alkaline waters were, these were mineral waters, but they were high in lithium salts. And they found that this seemed to help with mania. Now, you've got to realize the diagnosis. Obviously, they didn't have the DSM, BC manual back then. So, but then, getting a little bit closer, in 1949, Cade was using lithium carbonate and was using it to treat the manic depressive patients. And then what's sort of interesting was that same year, the FDA came in and banned the application of lithium for almost 15 years. What was happening was lithium was being used probably more frequently. People knew that sodium caused hypertension. So what people did to do the salt substitute was they were using lithium. And you can imagine the way people salt their food these days, it would not be unlikely that these individuals could easily develop lithium toxicity. So from that standpoint, the FDA banned it. And then what we saw was the lithium came back in the 50s. 1950, Shao basically showed that he used lower doses of lithium and actually showed that they were effective for manic disorder. These were actually lower doses than Cade did. You have to remember, early on in the medical history, the tendency was when they were developing drugs, they used a lot of it. It was sort of like I'm going to use a lot to demonstrate an effect. And so people a lot of times really, used high doses. And what we've seen, especially as we moved into the modern era, 50s, 60s, 70s, there was a tendency to start finding doses that were lower. Finally, in 1970, basically the FDA approved, lithium was approved for bipolar disorder. So lithium has had an interesting history as it's emerged on. Previous slides, when I've taught this, has been sort of interesting because I used to have, probably under preparations, I think there was like five or six different lithium preparations that were here, because lithium was being used quite a bit. I think there's many more preparations that are available over in Europe. But primarily, we've come down to using lithium, and then there is a slow release lithium called Lithobid. Now, I did put an interesting note here, so be careful about this. And this is, sometimes I'll try to emphasize which one of these scenarios or which one of these drugs sometimes may have sound-alike names. But Lithostat was really not a lithium preparation. It's actually a drug used to treat urinary tract infections. I would think these days that the FDA would prefer that, for example, in renaming these drugs, the FDA now is a little bit more cognizant with regard to what you can name a drug. If there's a sound-alike name or something like that, then that comes, they will often not allow it. But Lithostat, you would think it's very easily, most people could look at it and would think that was an immediate release lithium or something like that. But again, this is, Lithostat is not a lithium concentration. I have I've had some lawyers over the years that have tried to say, well, this patient was on lithium and then was created a problem by giving another lithium concentration. And it's been sort of interesting because you sort of tell them, this one doesn't have lithium in it, okay? So with lithium, we find that it has been approved for acute management of mania and hypomania, and also used prophylactically. It has also been approved for acute and prophylactic treatment of the depression associated with bipolar depression. We wouldn't use it for unipolar depression for sure. But the question is some people have argued that lithium is really not that great for the depression part, although in some patients it does work. This is, of the mood stabilizers, this is the only one that doesn't have any significant anticonvulsant action. So when we start talking about, carbamazepine and so forth, those are going to have anticonvulsant actions. Lithium works well in some patients. Some studies, there's been a response rate of up to about 70%. It's not going to, it may take a month or two for this to actually work, but things that have been shown is it does reduce suicidality, which is one of the pluses. But what we find is that in patients that are rapid cycling and that have a mixed bipolar states, lithium can still be effective, but it's not as effective. There are other drugs that may be a better choice. If the person is, sometimes we see people trying on lithium. Lithium is pretty inexpensive. One of the things that you have to do, and I usually don't have you monitor or memorize lab values, but you will need to know. In fact, I think the past PEP exams that's the only thing that I'm aware of that they've had on it that you're supposed to know, and I will give you these serum levels in just a little bit. So when you have somebody on lithium, because it has a narrow therapeutic index, remember, narrow therapeutic index is where we have a drug that its toxic effects come very close to its therapeutic effects. So little changes can make big differences. So what we have to do is you must monitor serum levels, and you adjust those levels, adjust the dosage if you need to, okay? Typically, we are going to draw bloods roughly 8 to 12 hours after the last dose. That is the best preference. What we're trying to do is, again, just drawing bloods whenever. It's hard to see where you would be. So typically what we would prefer is 8 to 12 hours after the last dose. Now, there are a lot of theories with regard to how lithium works. And in fact, I'm going to give you a video to watch at your next break, which will take probably in about 10 minutes or so. And Aidan, I will send the link to you in just a few minutes. So one of the things is that lithium, and again, here's the thing with lithium. It's a pretty simple molecule. It is, and being a simple molecule, you would think, well, it's pretty easy to understand. So, but there's a lot of different things that has been postulated with how lithium works. I'm not sure that anyone knows the exact mechanism, the precise mechanism of action of lithium. So one of the theories is that inositol, which is a second messenger, is that lithium may actually cause a depletion of inositol. So what happens is that when a transmitter signaling molecule basically activates a receptor, what happens is that receptor activates phospholipase C, and what will happen is that IP3, which is inositol triphosphate, gets transformed to inositol. And then inositol gets used to resynthesize phosphatidylinositol. So what the theory is that lithium basically leads to an accumulation of the IP, inositol phosphate, and you actually get a depletion of inositol in the cells. One suggestion is it inhibits inositol monophosphate phosphatase. So the net effect is that one is that inositol, that lithium may deplete inositol, which is one of the second messengers. So here's where it goes into play. So in bipolar disease, you have hyperexcitable cells, okay? That produces excessive IP3, which is inositol triphosphate. That gets converted to inositol monophosphate, and then that is broken down by inositol monophosphatase, okay? It's an enzyme. So by inhibiting the inositol monophosphatase, basically what happens is that you increase inositol monophosphate. And as it accumulates, the large amounts of this basically results in the lithium having a high activity. So what we find is that, here's the theory, or the proof of why they think this may work, is lithium works in bipolar patients. And the bipolar patients have this occurring with the hyperexcitable cells. But if you give lithium to non-bipolar patients, pretty much you don't get very much effect unless you get really high doses. So that has been one theory that that's of how lithium may produce its effects. We know that when you start getting this, if there's not an alternative supply of inositol, then you start getting a depletion of inositol. And so there's a restricted amount of inositol in the brain. And that is what gets up, and the lithium can get into the brain, and that's what causes it. So then what happens is this inositol gets taken up in the cells by the sodium inositol cotransport. That's referred to as SMIT. And what we see is that lithium downregulates these. So it takes about eight days for this to occur. So this action with inositol, basically the way that they think it's involved, or the proof of it's involved, is that it seems to work only in bipolar patients. Secondly is that this fits with the delayed response that we get with lithium, which typically they're saying 1 to 2 weeks to get a response, and this response parallels that. So that's one mechanism, is we basically get, all I'm interested in that you knowing is one mechanism may be inositol depletion. And another thing that may happen is that lithium is it's a very simple molecule, and lithium moves like a lot of our electrolytes. So we do know that, as I mentioned earlier this morning, that one theory of bipolar disease is that there's an alteration in electrolytes. So lithium may actually modify the ionic mechanisms, which can then affect the membrane excitability. So in fact, what happens may be is that lithium substitutes partially for sodium. So instead of having much sodium, which comes in and causes the cell to discharge, is you get some lithium in there. And then the other thing is lithium may actually compete for calcium binding sites, and therefore would affect neurotransmitter release, that calcium can't get in to cause the release because lithium goes in. So that's another theory that is been postulated. One of the things that we see is supposedly the depressive component is that we have a deficit of serotonin. And one of the things that we see is that lithium can enhance the serotonin actions, and you're going, okay, that sort of explains why it may be effective. It could be effective as the depressant. So we do know that it will elevate the serotonin, it will elevate tryptophan, it will elevate the 5-hydroxyindole acetic acid, which is the metabolic metabolite of serotonin. And the idea of 5-HIAA goes up. That would suggest you have more serotonergic activity go on. May actually increase the release of serotonin. So you're going, hey, that's great. That should be explained, and lithium should work in the depressed phase, but we know that it's variable. On the other hand, while all of this is occurring, what may happen is you may get a downregulation of serotonin receptors. So you may actually get more serotonin released, but the receptors that are involved, they may actually decrease. So that may provide the reason why it's variable. It can enhance the uptake of norepinephrine and serotonin. That would alter serotonin and norepinephrine levels. It inhibits the release of norepinephrine. That would explain why that it may be effective in the manic phase. But because of these complexity of actions may make it very difficult to, that's what accounts for the variability. Again, it seems to work very good on the manic side and variable on the depressive side. When we're looking at lithium, there's two things. We're going to individualize the dosage. We are supposed to do this with every drug. When you are looking at all these different drugs, you would anticipate that you should be individualizing the drug, regardless whether it's lithium, whether it's carbamazepine, whether it's one of the atypical antipsychotics. But here's the key. You need to base that both on the serum levels and the clinical responses. An old adage that we always say is, you don't treat a lab value, you treat the patient, not the lab value, okay? The reason for that is that lab values sometimes can be off. Sometimes you can get an aberrant lab value that it is very difficult to determine why you got that value. I've got a case right now, and one of the things that we see is I've got a woman they've been around. She's been at work all morning long. She leaves work. This person is a healthcare professional. She has never had any issues. She's one of the straight and narrow people. She was in an automobile accident, and she has a lab value showing that she has methamphetamine. The hospital that evaluated her basically shows no signs of any stimulant actions. There's no pupillary dilation. There is no elevated blood pressure. There's no elevated heart rate. There is no clinical indices at all which suggest that she is under the influence of a methamphetamine at the levels that that they've reported. I have looked at the lab values. I've looked at all of the stuff. I cannot find any aberration in the lab value, but nevertheless, the issue is that if we went solely by the lab value, then she should be at almost toxic levels of methamphetamine. That's not the case. So unfortunately, they did not save the blood, and so we can't retest that blood. So basically, when you're looking lab values, it's so easy to default to them because they're quantitated, and that number is there, and you've got a range, and it just seems much more just easier to do that. So we don't want that, okay? So what you're looking at is lab values and clinical responses, okay? What we do see, as I said, this is a narrow therapeutic drug, or it has a steep dose response curve. So the doses or serum levels that produce the therapeutic effect are very close to the levels that it takes to get a toxicity. And it is possible that you can get toxicity at therapeutic dosages. That's why it's important to consider clinical response and therapeutic response. All right, not going to ask you guys dosages. So we're covering these, but again, at this stage, you can, when you're treating patients, you will get used to these doses, but I'm not going to be giving you any question like which dose range should you use, okay? So typically what we're going to see, and this suggests optimal dose response, but again, optimal response can vary between patients. You want to use the smallest dose possible, especially with a low therapeutic drug or with a low therapeutic index drug, okay? So typically we're going to use either 6 600 milligrams, maybe 3 times a day, or 900 milligrams twice a day. Now, I want to think about something. If we're given 600 milligrams 3 times a day, then if the last dose should be taken sometime that evening, which means that for pulling labs, the best time would be the first thing in the morning. Okay. So let's say they took a lot of people taking it 3 times a day. We'll take one in the morning, one maybe lunch or shortly after lunch or between, mid-afternoon, and then one in the evening. So if we're going to pull bloods, we want to make sure that patient does not take their lithium first thing in the morning. We'd rather have them show up at the lab, take their lithium, pull the blood, then take their lithium dose. Typically, these dosages will put them somewhere, should put them between 1 to 1.5 milliequivalents per liter. Now, remember with lithium, when we're talking about ions, instead of talking about milligrams, we talk about milliequivalents. That is the units that lithium will be measured in, okay? What we would typically do is we're going to start them on lithium and basically probably pull blood values, pull serum maybe twice a week, okay? We may do that for the next several weeks, next few weeks. What we're looking at to see when they're stable and when their blood values are stable, okay? What we want to do is have them at steady state. So does anybody know what is the how do we determine when they're at steady state? Sure. So Maribel is about 4 to 5. So it's typically 4 to 5 half-lives. So what we would do is get the half-life, and basically what we would do is look at 4 to 5 half-lives of that. And again, the slow release mechanism may have a slightly different half-life. So we need to, I was looking up, I think I gave you guys the half-lives there, but pretty much lithium half-life is around 24 hours. So what you would look at is probably, you would be at steady state probably somewhere around 4 days, 4 to 5 days, okay? But again, don't just, we need to make sure that the patient is stabilized too. If we get a lot of fluctuations with we should see a little bit of variation as this at the very beginning, but if we get wide fluctuations or something, we want to check, make sure the patient's taking their dose. We don't want some patients, like doubling up their dose or something like that. So that could create a problem, or taking all their lithium in the morning. So those would be an issues that we would try to avoid. What we ideally would like to do once we get them on maintenance is try to have them between 0.6 to 1.2 milliequivalents per liter. And we may end up, sometimes we can get them down to 300 milligrams. Sometimes that's equivalent. I mean, we can get them there for 3 to 4 times a day. And once they're stable, what we need to do is probably monitor them every 2 to 3 months. But we need to make sure the patient understands that if there is an issue that arises, i.e. that's starting to show, is trying to show that, we may have to come in, because there's things that can affect that. So Joy, the thing about it is that with the lithium, the idea here is that people are trying to go as low as they can with these doses. For example, if you look at the lithium, one of the things you may have to adjust it based upon what strength of the drug you've got, but we will try to use as low a drug as possible. That is just really trying to avoid any of the toxicity when we can. So, with Lithobid, a lot of times it'd be 900, 1200, but again, let's see for bipolar, and we've gone higher doses if it's acute manic. But again, the reality of it is try to use as low a dose as possible. So from a standpoint of this, to start off with, you're probably using a little bit higher dose than what was being used for SI. But ultimately, what you're wanting to try to do is to try to, patient stable at the lowest levels. And what you really want to be careful about is not letting those serum levels scoot over into a toxic range. Actually, this is a good time to take a break. Let's come back at, take about a 12-minute break. So let's come back and don't worry about the video. I'm going to give the video for you guys to look at tonight. And Aiden, I'll send you those links in just a few minutes. Let's just come back at quarter after. And this will be our big break this afternoon. And then we'll take a smaller break a little bit later. So come back at quarter after, and we'll pick up on lithium. And Aiden, I'm going to get these video links to send to you.
Sure.
When we're dealing with lithium, is that there's several factors that come into play. Again, keeping in mind, and this is like getting preached to you over and over, is that lithium works. It works pretty well in several patients, but you've got to be careful with it because of the narrow therapeutic index. So when you look at, we're going to be monitoring lithium values. And so things that you have to be aware of is to adequately interpret these values. What you have to look at is how reliable are they? Plus, again, we're going to be looking at the patient, but we're also going to try to use these lithium value to keep from the patient becoming toxic, but also to interpret maybe sometimes how the lithium is working. So what's going to affect the lithium values? These are the things that have to come into play. Number one is patient compliance, okay? This is a big one. You are dealing with bipolar patients. You are dealing with patients who potentially may be dealing with substance abuse. You've got patients that may be in a manic phase, depressive phase, so you've got the lability of mood there. You have concerns potentially with the caregiver, especially if it's an adolescent or a child. So one of the big things is patient compliance. Are they taking their lithium? Are they taking it when they should be taking it? Are they skipping doses? Are they taking it when they feel like it's working or feel like they need it, and not taking it when they don't take it? We already talked about the timing of the blood sampling. So basically, the ideal time would be typically first thing in the morning. Getting these lithium samples may be a problem too. I mean, you've got patients that are bipolar, and they may, depending on what phase they are, if they're depressed, they may not feel like coming to the lab. You've got the issue of whether they can have transportation to the lab, especially if you're dealing with an adolescent who maybe can't drive. We know that, we're looking at steady state taking probably close to 4 to 5 days. So one of the things is we would expect there would be some variability, and there would be some extent of that we had not reached the Cmax and Cmin, the maximum concentration, the minimum concentration. So that's another thing. And as Maribel, you mentioned, a lot of people sometimes like to tinker with their meds. We've had a couple of patients that are like to say they want to play with when they take them, take some when they feel like that, or take more of them when they feel like that they may need it more, and that sort of thing. We used to have this point down here is when we had a lot of different formulations there. That used to be more of a concern because you would have sometimes different people moving around would shift with the particular one that they're taking. we're down to really 2 products now, so that has reduced that variability. However, one of the issues that comes into play, generics. So, you know, there are a number of generic companies that come out with regard to it. I was going to look to see, let's see, with Lithobid, I think that there is just one. There's one extended release tablet for Lithobid. And but you know, if there are generics, that was a big concern. I was looking to see with regard to on lithium. So just looking at pulling up Epocrates on lithium, we've got, you know, we've got a capsule that goes from 150 milligrams to 300 milligrams. We have a lithium tablet. You know, we have several capsules. We have there's extended release. There's a lithium syrup. So there's a number of different preparations that are available, and different generics could make a difference. So that's one of the things that we want to be careful. Another thing, which although we make the assumption is pretty much where the lab, you know, the lab that's actually running the lithium. So one of the things that we are really, we assume that those labs are qualified and everything like that. But every now and then, I mean, even when I have looked at labs from the state crime lab, which is, you know, sometimes you see some differences. So if a value comes back off and everything looks good, just like I told you with the lady with methamphetamine, that's one of the big issues that we're trying to figure out is obviously the clinical picture of what we've got is not matching the lab value. So that can always be an issue that if everything else is checking out, sometimes it might be worth picking up the phone and calling the lab. You got to be careful when you call the lab. Sometimes the people automatically go into a defense mode, you know, assuming you're claiming something went wrong. But sometimes you can call and just say, I've got some unusual values here. I'm just trying to run these down. And I talked to a guy at Tennessee lab this last week, and he was very helpful, went through everything. And, you know, so, but, you know, that sometimes may be necessary is to look and see if there may be a problem with the machine or something like that, because those things do happen. Probably one of the two biggest things down here, right here. This one, changes in sodium intake or excretion. So number one is that people can alter their sodium intake, and sodium and lithium are going to compete. So sometimes if they alter the sodium intake, it can affect their lithium concentrations. If they get dehydrated, that can do it. Excretion, diuretics, big problem there. So one of the big things that we need to do is to, you know, make sure these individuals aren't having any, you know, wide swings in sodium intake or excretion. Sometimes individuals, from a standpoint of, well, I mentioned earlier today that one of the comorbidities may be an eating disorder. That could be a big issue. People that are throwing up could become hypovolemic. People drinking a lot of water can actually develop a sodium toxicity, wash out the sodium, which could affect the lithium. Plus, the sodium depletion could produce that also. And then caffeine and alcohol intake is going to also affect the kidneys and affect potentially the lithium concentrations. So Joy, one of the concerns with active purgers is, for example, think about you have a concern with regard to those purgers basically getting sodium depleted, getting dehydrated. And then the other issue that you got to worry about too is that if they took the lithium and then were purging, are they going to be, you know, throwing up any of the lithium? So that would, I don't say it would be contraindicated, but it is, it would be something that you would need to consider as to, and maybe monitor a little bit closer. When you look at contraindications, Really, the only thing they've got is, if their creatinine clearance is less than 30, and if they're sort of hypersensitive to to lithium. So those are two of the big contraindications there. But it's one of those things that you got to monitor closely. That would be where you're looking at is a problem. Now, there is one other thing which is sort of rare, which is called Brugada syndrome. Have any of you heard of it? Let me just put it down here. So Brugada syndrome is one of the things that's listed as a contraindication. And what Brugada syndrome is basically, it's a genetic abnormality in the heart conduction. And it's done by an EKG is primarily how it's done there. But these people are at risk for sudden death, and lithium can precipitate or cause this to occur. But that's very, very rare. But our biggest thing is going to really come into, like, for example, we have people that drinking a lot of caffeine. That's going to affect your renal. We're going to see a lot of people drinking alcohol intake. We can, drinking a lot, that can be an issue that is can be a major issue. So these are the things you want to watch for, and we're going to talk a little bit more about these now. This is along the same lines too, is anything that can alter lithium clearance. Caffeine can, alcohol might. We'll give you a few other examples like diuretics, big one. We need to be careful about certain disease states. Now, here's a trick question that gets thrown out there a lot is, how is lithium metabolized? Does anybody know what enzyme in the liver lithium is metabolized by? Doesn't get metabolized in the liver. Unless the liver is affecting functioning of the kidney functioning, which can occur, the lithium is not metabolized. It's basically excreted by the kidney. So that's always a little trick question that gets thrown in. A lot of people like to throw in to medical students is you have a person that has a polymorphism of cytochrome P4, 3A4. How does that affect the lithium excretion? And of course, most people, their default thing is they say, well, goes metabolized, and so polymorphism probably increases or decreases it, whatever they choose to do. It doesn't, because basically it doesn't go through the liver. So what we worry about disease states, primarily things affecting the kidney. Okay, we can have severe liver disease that can ultimately affect the kidney, but primarily what we're looking at is we're looking at things that would be affecting the kidneys more than the liver. Okay, alterations in diet and physical activity. This can affect sodium levels, which can affect lithium levels. Pregnancy, because lithium can be, we've got an issue with, you don't want to use lithium during pregnancy, and pregnancy changes renal flow and so forth, so it could affect that also. So one of the questions is, because we used to have all these different types of lithium, how do you choose the right product? And it really came down to, I've got patient preference, but it really came down to doc preference, prescriber preference. One of the things we run into is typically there is an issue of what if the patient can't take it, or maybe the patient doesn't want to take it. Sometimes people don't like the taste of the tablets. They may have difficulty swallowing it. So we have capsules. We also have the syrup, because there are some individuals that have difficulty that just have a real hard time swallowing capsules or tablets. And the other thing we see is just, tolerance of the side effects. Sometimes we'll see a person may have more side effects with a immediate release formulation than a slow release formulation. So that is really what comes down to it. And again, we had a whole number of products we used to have out there that have dropped off, and we now have extended release, and we have We have a lithium, including extended release, and then we have a lithobid. Remember, we don't have lithostat. That is not a lithium product. So now, here's the other thing that happens sometimes is that sometimes people are not aware. The pharmacist will usually tell the patient, but you need to be aware of this also. So many times we may be using combination therapy. Going back to that slide that had all the different things, on it. I told you just not to worry about it. But so sometimes we may use lithium, which would be effective for the manic side, and we may want to use an antipsychotic that may be effective for the depressive side and the manic side. So sometimes what we would see is, so we'd use the oral solution, and people would have the antidepressant, which may be, or the antipsychotic. Chlorpromazine they used to have a liquid there. So the idea is I'm going to dose them. Let's just mix the two together. Well, if the same pharmacy is filling both, they would let you know that you don't want to mix those, because what will happen is when you mix the two together, they precipitate out and it forms a salt, which is, it clumps up and just sort of solidifies there. So that was an issue, is that, again, when we took those, is that we don't want to mix them together. It's okay to take them, to swallow them one after the other, or sometimes they may want you to wait just a few minutes before you take the next one. But typically, as long as you don't mix them together, so you can just take one drink to get through them, because it'll just precipitate in solution. The extended release products used to be more expensive. Because of their expense, now we've got generics, which has dropped that. But a lot of times people, since the expense was so much more than the immediate release products, a lot of times the doctor wouldn't prescribe them because people didn't want to pay for them. And in fact, what we saw for the extended release products is they were used they tend to have less effects on producing nausea and also hand tremor, because you're getting a slower release of the drug. Okay, and so as a slower release, you're not getting as high a plasma value, so the toxicity may not be quite as prominent. Typically, we like to minimize, this is for every drug, it's not just for lithium, but specifically with these type of patients, we're going to try to get by with twice a day dosage if at all possible. Typically, we get better compliance there. We see sometimes people can develop polyuria, meaning they go into the bathroom a lot. And so we like to sometimes use the extended release products and give that to them at bedtime. And that tends to result in that they don't have to go to the bathroom as frequently. Children, we start with low dosages. Again, I'm not asking you to know the dosages. Sometimes we do this by total dose, or sometimes we may actually do it as milligrams per kilogram. I've seen it done both ways in children. Usually the younger the child, more likely to see it dosed on a weight basis. Whereas an older child, it's usually per day, milligrams per day. So I'm not interested that I don't want you to worry about knowing the dosages, but what I want you to notice, this should be true for the adults too, but we see doing it, but gradual increase in the dose. Monitor the dose so that we're going to use the lowest dose. But what we do want to do in the kids is, since lithium can have an effect on weight and height, is we want to monitor that. Typically, a pediatrician would be doing that. So what we're going to do is basically baseline and then at least every 3 months. If you're seeing the patient more frequently, let's say you're seeing them every week or 2 weeks, go ahead and get the measurements. It doesn't take that long to get those, and it just gives you a more complete record. All right, so let's look at the pharmacokinetics of lithium. Very simple molecule, okay? It gets absorbed easily from the GI tract. Most of the drug gets absorbed in the small intestine. Food doesn't affect it, so it doesn't matter if we take it with food or not. But typically we're going to see, this is referred to sometimes as Tmax. Put that out here so you can see it. It's usually T for time. And then, there we go. It's not Tmax, it's Tmax. Okay, so Tmax is the time at which the maximal or peak concentration occurs. That's many times you can get that with the product literature, or you can look it up fairly quickly. So typically what we're going to see is the peak levels are going to occur somewhere between 1 to 4 hours. As I said earlier, onset of action is usually 1 to 2 weeks. That's around 5 to 14 days. It's not protein bound, so we don't have to worry about those type of drug interactions. And then here's what we see. I want you to notice a couple of things. 24 hours in adults, 36 hours in geriatrics. Why do you think the difference in geriatrics versus adults? Exactly. Decreased kidney function. And take a look at what happens with impaired renal function. Look at this, 40 to 50 hours, okay? So what that means is we have to watch. There is a potential, especially in geriatrics and with patients with impaired renal function, that we really have to watch for accumulation. These patients we may be specifically monitoring a little bit closer because of a concern with accumulation. So we may have to adjust the dosage in these particular patients. Again, your key point is liver function is a concern, okay? And liver function is not as big a concern. It's the kidney function that's going to be the key thing. So again, take home is, on this bottom one is renal function decreases the excretion. And if it decreases the excretion, basically what's going to happen is the drug can accumulate and we can get toxicity. So typically what we're going to see is that we're going to be looking for a therapeutic effect. Now, so until the desired therapeutic is maintained, one of the things that we're going to try to do is keep their, once they're at steady state, so after 4 to 5 days typically, what we're going to see is, well, keep in mind that if you've got a person with impaired renal state, it's going to take you a little longer to get to steady state. So typically what we're looking at is that until we get the desired therapeutic effect, we're going to be looking at serum levels of about 0.8 to 1.4. Okay. That's what we're looking at. And then we're going to slowly decrease the dose back down to where we get what we're going to maintain them. And when we get them at maintenance, we should be between 0.4 and 1 milliequivalent per liter. Okay. One of the reasons we use this is because clinicians with drugs a lot of times are looking for a clinical effect. And so what they're doing is they're pushing a dose till they get the effect. ER docs are notorious for, as one of my colleagues who was an ER doc says, we hit them hard and move them on. So the idea is they hit them with, ER docs have a tendency to hit with higher drug dosages when they're treating things to try to get people stable and move them. But one of the things that you have to be careful about with this drug, you can't just keep dosing and saying, okay, well, I'm not quite where I want them, because you may see in a patient that you may never get them to the perfect scenario. So that's why we're going to watch these these blood levels, because we want to make sure that we're not just pushing the dose and get them into toxicity. Where we see is as long as we're below 1.5 milliequivalents per liter, as long as we're below this range here, typically, usually not serious, okay? Now, there's some qualifiers there, usually not serious. There can be a patient, which they can be, but typically most patients, as long as we're under 1.5 milliequivalents per liter, what we find is most patients do pretty good. Where we see really significant toxicity is when we start getting above 2 milliequivalents per liter. So your gray area is between 1.5 to 2. There are patients that can have some pretty serious toxicities emerge between that 1.5 to 2. So we have to be careful there. And again, what we said earlier is when we take the blood, typically 8 to 12 hours after the previous dose, don't make the mistake. You know, you want to tell the patient, don't take your lithium this morning, come to the lab, let's pull the labs, okay? So if they're at steady state and we're taking them 8 to 12 hours after the previous dose, typically we're going to see that these lithium values are pretty stable, okay? That's one of the reasons we say 8 to 12 days. So it works out well. They take the evening dose, and even if they take the dose, you know, think about it. If they took it at 8 o'clock that evening, then your 12 hours at the next morning at 8 o'clock, you would be 12 hours. If they took their dose right before bed, let's say they went to bed at 11 o'clock, you're still within 8 hours, you know, if they show up at the lab at 8 o'clock or something like that. But again, you don't want them to have taken their dose before you pull the blood, because what will happen, we're going to go through the Maribel, we're going to talk about lithium toxicity in just a moment. So typically this 8 to 12 hours would allow the patient to take their evening dose, and assuming they're going to come to the lab first thing in the morning, you know, if they're going to come to say, if we tell them to come in the morning and they show up at 11 o'clock, you know, it's not going to be there. We usually want them there, you know, just come to lab, and a lot of labs will allow them to pull, or physicians' offices, you can come in, you know, 7 to 7:30, 8:30 or so in the morning, and pretty much they'll pull the blood for you, or go ahead and pull the blood. So who are our high-risk patients? Who are the patients that if we've got them on lithium, it doesn't mean they're contraindicated. Basically means that there is a good chance that we could have lithium toxicity. Renal disease is pretty straightforward. I mean, the drug is primarily excreted by renal, and so there's no doubt that this is going to be a major issue. So if they've got kidney disease, it is going to be a concern. It is going to be something we want to be careful about. The cardiovascular disease, the reason it's listed there, one of the reasons is usually people with cardiovascular disease can have an impact on the kidney function, but it also can just overall cardiovascular disease puts the people at risk. Severe debilitation, they're weaker. Many times kidney function is down. A lot of times they may have a lot of other things going around. The more common things that we worry about in a patient, let's say, that is normal kidney function, no cardiovascular disease, or no severe cardiovascular disease, not an old person that's debilitated. Here's what we're going to worry about: dehydration, especially in the summer, especially in hot climates. Several of you in California, Georgia, this last week has been really brutal down here. The temperatures, I mean, we're the end of September and going into first week in October, and we've got temperatures in the upper 90s with the heat index kicking it above 100. Very easy for people to get dehydrated, okay? Older people we worry about because sometimes they just forget to drink. People outside especially in the summer and the hotter months, just don't stay hydrated. We see people drinking alcoholic beverages a lot that can lead to dehydration. Sodium depletion. And of course, that can occur with renal disease, but sodium depletion can also occur with these individuals getting dehydrated, sweating. We can see sometimes cutting back salt sometimes they can go to a sodium depleted state. People on diuretics, which is our next category here. And surprisingly, I mean, up until about last year, I would get probably anywhere from 3 to 5 lawyers across the country contacting me where someone had lithium toxicity and a doctor had prescribed diuretics. Um, Several of times these patients were on Lasix, a very high ceiling diuretic. But we also saw, I saw people on hydrochlorothiazide that would show lithium toxicity with those. The other group that you have to be careful about is people that have eating disorders, body dysmorphia. There are people that will buy diuretics over the internet or get them from their friends. So those people are another issue there. Many times when this is occurring, when we have these conditions, sometimes we may have to actually, especially if they've gotten into some lithium toxicity, we may actually be measuring their lithium concentrations daily until basically they get stabilized, and sometimes hospitalization is necessary. So I will tell you an instance that occurred I was aware of several years ago. Is a woman's husband was in the Navy. He was basically deployed, and they had 2 or 3 kids. So she was put on lithium, and the lithium was, she started feeling weird, getting tremors and so forth, and went in, her lithium levels were off, and at the upper level, and they had her coming in on a daily basis, and they were basically had told her that if she came in the following day and her lithium levels were still elevated, that they were going to hospitalize her. Well, here's the situation you've got: is one, is scared her to death. Two, she's got 3 kids in a new area, 2 to 3 kids with a new area, and her husband's not there, and who's going to take care of the kids? So these were some things that, and so the tendency would be that the person doesn't go in and get their lithium checked. That was not this was an older doctor that liked lithium, used lithium on almost all of his patients, thought it was the best drug, monitored his patients closely, but really did not work or talk to his patients with regard to the consequences of what might happen if if this got out of whack. And this was not a situation where the individual was not taking their medication right. There was just some other stuff going on, from what I understand. Now, these are some things, Maribel, you were asking about some of the things with lithium toxicity. So one of the warnings that you can get, so if you look at the package insert, there is what is called, and this should have been in red here, this is an encephalopathic syndrome. So, so make a note that this should be in red. So this is an encephalopathy, which can occur. The person presents with weakness, very lethargic, tremors, may be confused, actually has some EPS symptoms, serum enzymes are elevated, and sometimes this is when lithium is used as a neuroleptic, in which they give high doses. So that's one of the biggest concerns, is that sometimes when lithium is being, its dosage is being pushed to try to use it more as an antipsychotic type action. We don't see this, again, we've moved more and more to using lower dosages. The problem is lithium will get to the brain. We know that's how it's working. And this can get in at high doses, can produce actually irreversible brain damage. If we start seeing this emerge, then obviously we want to discontinue the lithium at the first sign of some of these symptoms. There is a black box with lithium. And a couple of things that you should be aware of is, first of all, it's recognized that toxicity is related to serum lithium levels. This is going to tell us that basically we need to be measuring serum lithium levels on a regular basis, okay? The other thing it points out, because sometimes people get in their mind, oh, that only occurs at high dosages. But again, remember, this is a narrow therapeutic drug, okay, narrow therapeutic index drug, which means that basically that these toxicities can occur at doses close to therapeutic levels. So sometimes you don't want to get into the mindset that if it is occurring, I mean, as long as I'm giving a dose that's in the range, I don't have to worry about it. No, you don't want into that mindset, because it doesn't take much, and some patients may be a little bit more sensitive. The The other thing that could easily happen is we may be dealing with a patient that is maybe sodium levels have changed or whatever. So one of the big things is facilities for prompt and accurate serum lithium determinations should be available. What that means is you may have facilities at your hospital, but if your patient is not accessible to where they can get these labs, it's going to be difficult for you to do that. So sometimes when they go, oh yeah, our lab, our hospital can measure that, but you got to look where your patients are. Because if the patients, you know, a patient should be able to go to any hospital and they should be able to pull lithium levels, okay? But some of you have worked in areas which are very rural. Some of the places, for example, in New Mexico like that, may have a situation which it may be more distance, you know, much more distant than what you think. So the ability and your patient's ability to get there. What if you've got a patient that can't drive and has no one to drive them? Maybe that we have some people up in the Appalachians that basically, you know, they do not have, they don't come to town or a hospital and there's no way to get them there. So when you're using lithium, you have to choose a patient, and you realize that not only there's a number of things you have to look at the patient may do, but you also have to have the facilities in order to be able to measure these and monitor these serum lithiums. The other thing you're going to need is, like, for example, you need these numbers fairly quickly. You can't send them off to the lab and, you know, wait sometimes 4 or 5 days for the lab to get them back to you. We've talked about this already, but what we've seen is that in some patients that are on lithium, some people have tried to argue that this is an effect of lithium. We don't know that, but we've seen that in somewhere between 10 to 20% of the patients that are on chronic lithium therapy, they develop kidney. We've actually seen that in some manic depressive patients, they've never been on lithium, that they may develop renal function impairments. Something else may be going on. We don't know. But it's important to be aware that renal function is going to have some degree. We have seen with patients on lithium that it has occasionally developed a renal nephrogenic diabetes, okay? So what happens here is that the lithium may affect the kidneys, and these individuals get polydipsia, which means they're thirsty, and they develop a polyuria. This is typically patients that have developed this. Again, it's relatively rare, but patients that have developed this usually on chronic therapy with lithium. So we should pick that up pretty quickly if we're doing what we need to be doing with these patients. Is anything that changes any indication of renal function basically should flag us to see if there's an issue going on. The elderly, obviously we have the age-related decrease in renal function, so we tend to have more incidences of toxicity with lithium in the elderly. How do we get around that? If we're going to use lithium, use the lower dosages, and we probably are going to take more bloods to make sure that they're staying in the therapeutic range. It will cross the placenta, and these levels in the fetus can be as high as what we see in the women, in the mothers. We also see it goes into breast milk. It's not recommended to breastfeed when someone is on lithium, when the mother is on lithium. So that's concerns with regard to that. When people are running fevers, one of the things that's often, they have an infection around fevers, we need to watch it. Sometimes we may need to lower the dose. When people are running fevers, sometimes their kidney function decreases. Lithium, especially at high dosages or when you first start, or maybe when you increase the dose, individuals may become a little obtunded. Their alertness may decrease a little bit. And what we find is that sometimes when we're giving people in their acute manic phase, they seem to be tolerant to the lithium. but then as the manic symptoms subside, the lithium seems to be working. Here's a big thing. We also, while we want to monitor hypothyroidism, remember yesterday we talked about the hypothyroidism. Thyroid dysfunction in general could cause mania, but one of the things that can happen is we do see a small percentage of patients that may actually develop hypothyroidism with the lithium. So we want to monitor thyroid function with people on lithium. We can see sometimes enlargement of the thyroid gland. So again, we should pick that up. And here's the big thing. Another big issue here is that lithium is going to compete for sodium. So what will happen is that your body's not going to reabsorb sodium when you're on lithium, so you can get sodium depletion. So it's important that people maintain normal diet and salt intake, but not excessive, okay? And we expect them to be staying hydrated. What we worry about, what we tell them if they have extreme bouts of diarrhea, we see that they're sweating profusely. There's a guy that lives down the street from me that he goes out, he's an elderly gentleman that he has planted like 3 trees in this big yard. It's just like these 3 trees. He is out there in the middle of the day. It's like babying those trees, and he is just drenched. So one of the things that we worry about is sweating, diarrhea. You could add vomiting in here. Those things could result in sodium depletion, which may make the lithium much more prominent, the effects much more prominent. This will be the last break this afternoon. So let's come back at 5 after the hour, and we're going to talk about things that we need to monitor with lithium. And I'll see you guys at 5 after the hour, okay?
Doctor, I will also run the poll right now, the attendance.
Okay, that sounds good. So when we're monitoring, again, we've gone over and over about the necessity for monitoring these patients, especially for their serum toxicity levels. So one of the things is that's occurring is basically we're going to be looking at a lot of things. So let's take a look at what you should be monitoring. Okay, so we've already talked about we're going to measure this, and this is going to probably until they're stabilized, as I said earlier, probably twice a week. But you may have a patient that you may need to monitor more than twice a week, or again, it just depends on that particular patient. But in addition to that, we're going to run a metabolic panel on them. So we're going to get serum creatinine. That's going to give us an idea. What is this going to give us here? What function is this going to give us? I'm going to test you guys a little bit here. Right. So serum creatinine is going to give us an indication of basically kidney function, and that's a routine one. We're going to get BUN also, so blood urea nitrogen, and so we're going to have those 2 measures in a metabolic panel. CBC is going to give us, with our complete blood count. Now, urinalysis may or may not be ran. I mean, sometimes we've seen situations where a person, does not necessarily pull a urine sample. When we're talking about a urinalysis, we're not talking about, for a drug test. We're talking about looking at kidney function. What we're going to be looking for if we do pull the urinalysis, is there any evidence of kidney infection? The urinalysis can give us specific gravity, gives us an idea of hydration, can tell us if there's any blood or anything present. Sodium and potassium, electrolytes in general. One of the big things is the sodium levels. Fasting glucose would be great. We don't always see that pulled. An ECG may not always be done, but that would be good to get. And obviously thyroid function tests. So all of those would basically come into play with regard to these particular patients. Again, metabolic panel. One of the things that sometimes happens is, for example, individuals come in, they get focused on lithium, so all they do is they check the lithium. but most of the time we'll get, metabolic panel before, but again, a lot of this we'd want to measure to make sure that they are a good candidate for the particular drug we're going to use. But, again, whether we do all of this every time they come in, that is going to be dependent on the particular patient. Now, side effects. And again, this gets back to Maribel's question that we'll go into a little bit more. All right, so typically, as long as we're under 1.5 milliequivalents per liter, seldom encountered. I mean, let's put it this way, serious side effects are usually seldom encountered, okay? When we start getting between 1.5 to 2, I told you that was sort of the gray area. That's considered, we might get some mild to moderate toxicity there, so we have to be careful there. But when we get above 2, that is when we tend to see more of the severe toxicity. So this is when you start getting above 2, you really want to take a look at what's going on. Probably when you're 2 or above, you're going to probably person is going to be manifesting some signs of toxicity. So what would we expect to see? All right, in general, most patients, in fact, one of the things a lot of times, if I were to, one of the questions that sometimes shows up in medical school and things like that is patient presents with you showing fine hand tremor, and is suspected to have a drug interaction. One of the things pretty commonly that occurs is lithium can cause that. So this fine hand tremor can sometimes be a major issue. If the person is needing the use of their hands, maybe let's say they're an artist or they're, doing something where they need fine control of their hands, a watchmaker, somebody like that. That could be one of the reasons why lithium may not be a good choice for them. But fine hand tremor is not uncommon. Many times they will complain of polyuria. They're going to the bathroom more frequently and a little bit thirsty. Okay, those are not uncommon to be pretty much throughout treatment. Okay, one of the issues becomes is whether your patient will tolerate it. And because if they don't tolerate it, they're not going to take their medicine. And if they don't take their medicine, it's not going to do them any good. Or they may take their medicine erratically. Typically, it's not unusual for when we first start them that first week, they may be a little nauseous, may feel just sort of just out of sorts, some general discomfort. Typically these things, as long as they don't completely interfere, I mean, again, each patient is different, but a lot of times those things will subside except for the first bullet point. One of the things we might do is if these are occurring, we might reduce the dosage and see if we can, these are considered dose-related effects for the most part, and sometimes a reduction in dosage may minimize these. So that's one thing. Concerns that we have is that on the cardiovascular system, lithium may cause arrhythmias. That's one of the reasons we want an ECG before. We can see some hypotension, blood pressure may drop. So it's generally sort of a depressant. If you think about, we're using it to sort of suppress mania. So it's putting the brakes on it. It can generally have a depressant action there. So what we want to look for is to see, if somebody has existing arrhythmias, this may not be a good choice for them. Hypotension can occur. That can result in sometimes them feeling really, dragging around. It could feel that sometimes that we want to make sure their blood pressure doesn't drop too much. We can get some orthostatic hypotension sometimes. So that can be related to sometimes the low blood pressure and the low heart rate that can occur. Neuromuscular, like I said, the tremors are not uncommon. Fasciculations or some muscle jerking that can occur. Sometimes difficulty walking, hyperactive reflexes. And then neurologically, there's a condition known as pseudotumor cerebri. What this is basically you get an increase in intracranial pressure and papilledema, which is some swelling in the brain. And what these individuals typically will present with is that the visual field becomes constricted and they can actually go blind. So these are some side effects that we are, you know, we'll have to watch out for. The central nervous system, a lot of things that can occur. People can have blackouts. They can have, when I'm talking about blackouts, they may not remember things. They can have seizures, slurred speech, dizziness, vertigo, urine or fecal incontinence due to actions up in the central nervous system, somnolence, confusion, dystonia, which is altered muscle tone, can even go to a coma. Our biggest things that we probably see would be, more commonly see, is probably the somnolence, maybe some dizziness, and potentially confusion, but these other things can occur. Again, most of these are considered dose related, and being dose related, sometimes a reduction in dose is all we need. The other thing that happened is it may be that something has changed so that the dose that we're using, for example, renal kidney function has changed. They've become dehydrated. They've been on a diuretic. GI, a lot of times they may lose their appetite, but typically we see some nausea and vomiting, primarily nausea, but they can have dry mouth. Sometimes they can get some salivation that occurs. In the genitourinary tract, probably the biggest thing is polyuria. They go to the bathroom more frequently, but we may see some glycogen in the urine or albumin. Probably the number one thing patients complain about is right here: excessive weight gain. I know a lot of patients that have gone on lithium and it's done well, but they do not like it because they put on weight. That is probably one of the biggest complaints we see, other than sometimes individuals may have some of these other little things going on that are usually dosage related. Some people complain about a metallic taste in their mouth. That can be bothersome. And then Raynaud-like syndrome sometimes occurred. This is where the blood vessels in the extremities, hands, the feet, the nose, around the ears, they constrict. And that can occur within about a day of therapy, and that may be bothersome. The Raynaud syndrome, basically the blood vessels constrict, and it makes the hands ischemic, so it makes them hurt, and that may be exacerbated. Tends to be more frequent in women. So typically, most of the things that we're seeing is usually dose related, and it's either that we've given them too much or something has occurred in which the lithium is not being excreted. So that's why if we watch carefully, then by adjusting the dose, typically these signs of toxicity will decrease. Typically the weight gain doesn't really do that. So what we typically do is if some of these symptoms seem to appear, first thing we want to do is try to find out why they occurred. And one of the things that, if we know that maybe they were put on a diuretic, or one of the things, maybe they're taking a non-steroidal anti-inflammatory drug over the counter. So correct that, and then we can usually resume treatment, typically at a lower dose, somewhere around 24 to 48 hours, but again, monitoring them carefully. If it is severe toxicity, potentially life-threatening, we may have to do something like hemodialysis to actually get the lithium out of the body. Few drug interactions that occurred. These are not usually due to a interaction at the liver, but can be either due to interference with the kidney or would be a pharmacodynamic interaction, which means that we may see an increased effect because of a combination of effects not adjusting the lithium. So carbamazepine sometimes has been combined with lithium. And what we find is that sometimes we get, since carbamazepine is acting in the brain and lithium's acting in the brain, we may get some increased neurotoxic effects. That can even occur at therapeutic levels. Haloperidol, same type of thing. Fluoxetine, we've actually seen an increase in lithium serum levels. That has been suggested to be possibly an interaction at the kidney. That's really the only way you can explain the increased lithium levels, would be with that. Key ones, these I definitely want you to be aware of. Number one, loop diuretics. And in fact, what you can say is basically diuretics in general. So the loop diuretics are more of a concern because they are so powered. They can actually, both diuretics, thiazides and loops diuretics, the loop diuretics is like Lasix. Thiazides is like hydrochlorothiazide. Because the loop diuretics are much more potent, you can get a much more dangerous situation. But even the thiazides, from a standpoint, which are considered minor or lower potency diuretics, can increase lithium levels. So we really don't like individuals being on a diuretic. One concern we have is, that people may buy these to lose weight, borrow them from their neighbors, or even get them off the internet. So that's a big concern. The other one, and this becomes an issue, is non-steroidal anti-inflammatory drugs, okay? The reason this is so important is because these are OTC, okay? So this includes ibuprofen, it includes naproxen. So these can also show up sometimes in combination drugs. For example, people that are taking opioids. There's a lot of times we see hydrocodone, oxycodone, tramadol combined with either with ibuprofen. That's very common. So one of the things that we see is that the NSAIDs, as I've talked to a lot of people that have dealt with patients on so anyway, that's a biggest issue that is coming into play, is that these patients may take these and not be aware of it. So that's one thing we need to also make sure that we need to make sure we counsel our patients on, is about these non-steroidal anti-inflammatory drugs that may be picked up over the counter. Verapamil, you can get some toxicity that may be due to the interaction or interference with calcium. But the other thing that you may see with verapamil is verapamil can drop blood pressure and heart rate, which may produce some toxicity there too. The phenothiazines, which would include a lot of the conventional or typical antipsychotics, we can see increased neurotoxicity because they can be depressants up there. But with the phenothiazines, also keep in mind that some of you mentioned this last week, the phenothiazines can sometimes interfere with may be used as antiemetics, anti-nauseous drugs. And so sometimes people forget about them. So Phenergan is a good example of that. So we can see they can be neurotoxic, and they can add to it. And then the tricyclic antidepressants, we see actually potential increase effect of the TCA. So we may see more of the anticholinergic actions. And this is probably from a standpoint of potentially interacting with the reuptake site. Let's see. All right. So here's what I want to do. I want to introduce carbamazepine. We'll start talking about it. Let's go through its medication, its mechanism of action. And then after we do that, Aiden will put up the last test. And Aiden has given you, or Aiden, you've got 2 videos that have been posted for you guys to look at. One is dealing with the mechanism of action of lithium, and the other one is living with somebody that's bipolar. So that'll be sort of your homework tonight. You might want to also look over those other 2 papers. So let me introduce carbamazepine, and then tomorrow we'll cover a few more of these drugs, but you guys are going to have a bipolar case to deal with also. In fact, what I'll do is I will send the bipolar case so that you can look at it tonight, and then you'll actually work on it tomorrow. Okay. So for a long time we had lithium. Okay, and so lithium was effective and it was a good drug in some patients, but The big concern was that we had the big issue of the toxicity. So really the first drug that was seriously studied to look as an alternative to lithium, again, we had lithium and we had those, typical antipsychotics. They had a lot of toxicity too. But carbamazepine basically became the first medication that was seriously considered as an alternative to lithium. So it was initially marketed as an anticonvulsant. We do see it used as an anticonvulsant. And it was also used for some pain syndromes, paroxysmal pain syndromes, which are these pain syndromes that come and go. What they discovered was carbamazepine had some very acute anti-manic actions. We saw it as anti-manic, we saw it as antidepressant, and it actually, in the clinical trials, looked like its prophylactic effects were very comparable to lithium. So here you see this drug that seems to go well, and although it's got some toxicities that we have to consider, one of the big things that it has is that it seems to be functioning pretty well, but not so much problems with it being such a narrow therapeutic index drug. So, and in fact, what we saw is that there was some evidence that the carbamazepine may actually be a little bit more effective in lithium in patients that had severe mania, or that patients that were rapid or continuous cycling or had mixed episodes, which lithium had very variable effects. And so carbamazepine seemed to work a little bit better. Good number of patients with acute mania responded, about 60% in some of the early trials. 50 to 60% showed a good to moderate antidepressant response. So people really were thinking this drug was potentially a better, maybe a better alternative to lithium. It worked pretty well as a prophylactic drug. The biggest thing we saw, though, is that people on it for long term, we started seeing some complaints of loss of efficacy. And that actually can be explained by the enzyme induction. That carbamazepine, even as an anticonvulsant, one of the things that we see is as the drug works, it induces its enzymes, so it induces its own metabolism. So we also saw in some of the studies that patients that didn't respond to lithium, a good percentage of them actually responded to carbamazepine actually fairly quickly within the first few days. So when we looked at it, a lot of things that were there that looked very positive. So it was good for managing aggressive behavior. That was a good plus, especially in some of this aggressive behavior we saw in adolescents. We saw that people that had severe mania, that had anxiety, dysphoria, brain damage, schizoaffective disorder, several of these things here, carbamazepine seemed to work pretty well. So let's cover this mechanism of action, and then we will let you take your exam, and then you've got a few things to do tonight. So one of the things we noticed is carbamazepine structurally is very similar to tricyclic antidepressants. So one of the things structure-activity relationships tells us is that when drugs have similar structure activities, they're going to probably have similar actions. So we have to be careful with these drugs if someone is taking a tricyclic antidepressant. We know that it blocks the reuptake of norepinephrine. We know that it decreases the release of norepinephrine, and it decreases dopamine and GABA turnover. So we know all of these things, but the exact mechanism of action, we're not really sure. There's been a lot of theories, but probably relates to some of these effects here. So let's stop there. That's a good place to stop, and we'll go into some more of this. Like I said, Aiden has put up 2 videos for you to watch. The mechanism of action of lithium is about 2 minutes. The talk about living with a person with bipolar, which is actually a TED Talk, is I think about 15 or 16 minutes. And then I'm going to send him the case study you guys will work on tomorrow. So you can look it over, but I'm going to give you a little bit of time in class to work on it tomorrow also. So Aiden, you can put up the quiz. I'm going to sign off, and we'll go over the quiz first thing in the morning too. And Aiden, I'm going to send you very shortly this case study. So otherwise, you guys finish up. I will see you tomorrow morning at 9 o'clock. Hope you have a great evening.
Thank you, Doctor. I'll keep the poll on for 10 minutes.
Sure.